Dr. Lindsay Cameron. She's an assistant professor in the Department of Pediatrics, Division of Pediatric Infectious Diseases at Baylor College of Medicine and Texas Children's Hospital. She sees patients in the inpatient and outpatient settings at Texas Children's Hospital and is one of 3 physicians who evaluate and treat pediatric patients in the Pediatric Tuberculosis Clinic at Texas Children's Hospital. Her academic research is focused on treatment and prevention of tuberculosis in children. During her pediatric infectious disease fellowship training, she completed a feasibility study to educate, screen, test, and treat adolescents for tuberculosis in 2 area high schools in Houston. She found that school-based screening and treatment is feasible and believes this may be an acceptable option to identify children and adolescents at risk for tuberculosis who are not otherwise identified. She is currently conducting both a retrospective review to side effects associated with once-weekly isoniazid and rifapentine in children and adolescents, and a qualitative study to interview patients visiting the tuberculosis clinic to improve educational materials for parents and children who are seen in the TB clinic. Please welcome Dr. Cameron.
Thank you so much for that warm introduction. It's so exciting to be here, especially with attendees throughout the globe. I'm going to share my slides. Let's see. Okay. So as Delphina mentioned, I'm going to speak on the global epidemiology of tuberculosis in children, adolescents, and pregnant patients. I have nothing to disclose. And this is the outline. I'm hoping to review some basic TB definitions. And the reason I want to do that is I want to make sure that we have a common playing ground on how we interpret the risk of tuberculosis in a child, and also how we identify populations at risk. In that context, I'm going to also discuss the limitation in estimating tuberculosis in children and pregnant patients, and provide an overview of the TB epi in children and pregnant patients that we have available. Also discuss the impact of COVID-19 on tuberculosis throughout the world. And then the fun part is where we have a case-based discussion at the end, followed by Q&A. So as you all know, TB is a very old disease. It's affected people for over 9,000 years. And this pictorial actually shows a statue from the Alexandria time period in the middle of the 3rd century BC of a person on the street who actually suffered from spinal TB. And as you can see, looked like suffered from significant malnutrition associated with disease as well. In the past 200 years, it's killed approximately 1 billion people. Despite these limitations, in addition to it being affecting populations for so long, the WHO remains committed to ending tuberculosis. And as this pictorial highlights, it takes a multi-sectoral approach that we have to mitigate aspects of poverty, homelessness, malnutrition, poor education, working populations within female populations, et cetera. And that all of these sectors are super important that need to be addressed in order for us to mitigate tuberculosis worldwide. From a pediatrician's perspective, but I think it's very, very important that we focus on the aspect of TB prevention and treatment of children at risk for tuberculosis, because I feel like that focus is the most important aspect of trying to mitigate the onset of TB disease later in their lives, in addition to the adult onset tuberculosis. And so if we work together in trying to address the needs of this pediatric vulnerable population, I'm hoping that we can end TB in a more expedited fashion. So I wanted to start out with a very poignant clinical case that we actually saw at Texas Children's Hospital, which I think highlights a lot of the points that I'm going to talk about later. This is a US-born 14-year-old female who was actually born in the United States, but moved to Reynosa, Mexico. And she developed symptoms of tuberculosis in April of 2020. She developed shortness of breath, exercise intolerance at that time, and had a 33-kilogram weight loss, in addition to cough. This is where she was living with her mother when she developed her TB symptoms. Her original chest X-ray, as you can see here, showed profound damage to her lung parenchyma. She was started on RIPE therapy in Reynosa, Mexico, and that she was confirmed to have culture positive tuberculosis that was identified as pan-susceptible, and that she had positive smears on the 24th, the 25th, and 26th. She moved to the United States to live with her grandmother in the May of 2020, and her clinical symptoms improved. She had negative cultures beginning in May, one in early June, and one in early July, and that she was enrolled in the binational TB treatment program at that time. She started video DOT during the week and self-administered on weekends. By the time we saw her, she had missed 13 doses, but had done really well with her treatment. She had serial chest x-rays that in August after treatment had shown some improvement, and then in December it showed blebs. So she had a very complicated social situation. She was back and forth from her grandmother's setting to Reynosa, Mexico. She was diagnosed with depression, and that she moved permanently to live with her maternal grandmother in early 2021. In January of 2021, she developed acute onset shortness of breath and was taken to an outside hospital. And at that time, there was concern for pneumothorax. They placed a chest tube, which was then removed prior to transfer to Texas Children's Hospital. On exam, upon arrival to Texas Children's Hospital, she was malnourished. So she weighed 84 pounds, which was 38 kilos, which is 0.7 percentile for her age. She appeared thin, she had a flat affect, and had decreased breath sounds diffusely, especially in the right lung fields. She was anemic, her hemoglobin was 10.4 and had normal LFTs. She did have a positive T-spot, although it was just borderline, and she was confirmed to be HIV negative. Sputa were collected on admission, and they were all 3 smear negative. And this was her chest x-ray on admission. So compared to the prior, it still shows pretty extensive disease, including all of these blebs. And that her CT tests also showed the lung parenchyma destruction that was seen on chest radiograph. So we continued her on right therapy, and that her microbacterial cultures were eventually negative. She actually needed multiple chest tubes for acute on shortness of breath due to concern for rupture of these blebs, and that she needed extensive nutritional rehabilitation. She was hospitalized for months at Texas Children's Hospital, and that she showed dramatic improvement in weight gain. Once she was determined to be sufficiently nourished, she actually was taken to surgery in February 2021. For a right thoracotomy and blebectomy, it was called, and then a pleurodesis. And that the pathology actually showed marked chronic inflammation, and the right lower lobe that was actually biopsied showed necrotizing and non-necrotizing granulomatous inflammation, but no acid-fast organisms on AFB or phyte stains, and that she was culture negative at 6 weeks. So she did not have multi-drug resistant tuberculosis, which was one of the concerns that we had. And so this was her post-operative chest x-ray. As you can see, one of those blebs were actually taken down, and that her pleura was bound to her chest wall. She had substantial expansion to her chest wall. And this was her post-op CT scan, which actually showed significant improvement. So she was continued on INH, RIF, and ethambutol, and for an additional 4 months. And so she completed a 1-year course, and that she was discharged home so that Hidalgo County Health Department could continue her treatment. I think this case highlights the importance of prevention and treatment of tuberculosis worldwide, especially in this child who unfortunately suffered from what a lot of our population suffer from poverty, from social disruption, and that this child unfortunately suffered from really severe tuberculosis that potentially could have been picked up earlier. So TB is a disease of poverty. As you guys all know, TB is known as a disease of the poor, and the burden of TB follows strong socioeconomic gradients between and within countries, and also between the poorest communities with the highest TB incidence. And that 95% of cases worldwide occur in low and middle income countries. This is a gripping article in Nature that's available via that QR code as well, that correlated the WHO data with GDP index per country. And as you can see, that there's an inverse correlation between GDP and TB incidence, that those that had a low GDP had the highest incidence of tuberculosis. And that they highlighted this family that was unfortunately suffering from poverty and the social complexities of poverty, and that all were affected by tuberculosis in some way or another. They lived in Khayelitsha, South Africa, which is a township outside of Cape Town, South Africa, and that all were affected with TB disease except for this little baby who was exposed to tuberculosis and was receiving preventive treatment. But this girl also had TB disease. So how do we identify children at risk for tuberculosis? First, we have to identify those who've been exposed. So we define TB exposure as a young child, and we focus on those less than 5 years of age who've been in contact with a TB case. They are often asymptomatic, have a negative chest of infection, a normal physical exam, and a normal chest radiograph. Some of those who are exposed go on to develop TB infection. TB infection is defined as a child who remains asymptomatic, but at this time they actually have a positive test of infection, either a positive PPD or an IGRA. They have a normal physical exam and a normal chest radiograph. And that those who develop TB disease actually have to go through those other two phases, right? They have to be exposed to someone with contagious tuberculosis. They develop infection, which is the asymptomatic phase, and then they go on to develop symptoms. So they have symptoms suggestive of tuberculosis. They often have a positive test of infection, so PPD or IGRA, and that they often have some types of abnormal radiograph or imaging that's suggestive of either intrathoracic tuberculosis or pulmonary TB as highlighted here, or extrathoracic tuberculosis based on an ultrasound or physical exam findings. And that most mycobacterium tuberculosis is transmitted to children by adults or adolescents. So that young children don't transmit TB to each other, but that they actually receive it from someone that actually coughs up the TB germ because they have a higher burden, and that tends to be adults or adolescents. So this little baby was exposed likely to one of its older caregivers, right? So the mother or the grandparents who had tuberculosis and not the sibling. But the sibling also inhaled the TB germ, became infected, and then developed disease because of a shared social contact, either within the household or a close contact outside the household. So a child newly diagnosed with TB is considered a sentinel event indicating recent transmission of tuberculosis in a community. And that we as pediatricians think that the focus on children is so important because children who are infected with TB remain a reservoir for them to develop disease themselves later in life, but also for adults to develop disease later in life. So how do we identify children at risk for tuberculosis? So contact investigations, which occurred in that Kylie family, in trying to identify who was the person that was spreading the TB to the other individuals, and then who was surrounded by them, who was at risk of infection or disease as well, is conducted in order to identify those at high risk for tuberculosis. And that many of you actually do the work, the hard work in trying to identify those who are at risk of tuberculosis or had TB prior to immigration. And then also pediatricians in the field do risk factor-based screening. So they ask about exposures to TB contacts or birth or extended travel in TB settings, or regular exposures to high-risk adults in different settings. And the probability of infection of a child depends on their intimacy and the duration of their contact with the source case, and then the infectiousness of the source case as well, but also the virulence of the bacterial strain. And the shared environment is very important as well. This was a beautiful study that was published in 2004 by researchers who are very well known in the pediatric TB world, who evaluated the clinical epidemiology of childhood pulmonary tuberculosis in the pre-chemotherapy era, and that they actually did a retrospective review of studies that actually followed children longitudinally after their exposure to a source case, and then to see who developed positive tests of infection, symptoms, or TB disease, and then death. And that what they found, strikingly, that those who are exposed to a household contact who was smear positive, that up to 80%, so 60 to 80% of children were infected. And that those who were exposed to a household contact who was smear negative, that 30 to 40% became infected, right? So this person is still contagious, even if smear negative. That's very important. And that 60% of children were infected in less than 3 months of exposure to their contagious source case, and that this was based on their TST conversion. And that more than 80% of those less than 2 years of age who were exposed to a household contact or close caregiver were infected with TB. Up to 70% had chest X-ray abnormalities, and up to 80% of those with chest X-ray abnormalities were actually young, so less than 2 years of age. They found that this type of environment that was an open ventilated area and non-household contact was less risk, but of course this was complicated by poverty. And that they found when they calculated the risk of developing TB infection versus those who went on from infection to progress to disease versus those who developed TB-associated mortality, actually varied by age group. And they found that those who are highest risk for developing primary infection were actually those that were a little bit older. So 5 to 9 or 15 to 24. And they felt like this was just due to increased mobility and their mobility in being exposed to multiple potential source contacts. But those of the youngest age groups were at the highest risk of developing TB disease after being infected. The highest risk was in those less than 1 year of age, and followed by adolescents. And that those who are more likely to die were those less than 4. So this is why it's very important for contact investigations to try to identify young children less than 5 who are at highest risk of infection progressing to disease, in addition to those who die from TB complications. So as I mentioned in those prior slides, infants are at highest risk of not only infection progressing to disease, but also developing really severe tuberculosis. So up to 40% develop TB meningitis, up to 20% developed miliary tuberculosis, and that those less than 5 also have increased risk, and that the highest risk is in those less than 2 years of age, where up to 20% actually develop TB disease after they're infected. And then adolescents also have an increased risk, up to 20%. And this is in comparison to 5 to 10% of adults actually develop infection after a disease after developing infection. Those who are of school age were considered to be in a golden period in the sense of that their infection was less likely to progress to disease. Other high-risk groups, which you guys know of, include any child with a primary or secondary immunodeficiency, especially those that are on chemotherapies, chronic steroid therapy, or high-dose steroid therapy, those new biologics, anyone that's severely malnourished, anyone with renal disease, or who suffers from diabetes. So as I mentioned prior, that adolescents are a little bit easier to identify who have TB disease, and that because they're more likely to develop symptoms, be contagious, and actually have radiographic evidence that's suggestive of them being smear positive, which means cavitary TB. They have reactivation of primary infection, and so they develop adult type TB. They're smear positive and PCR positive often because they have cavitation in the upper lobes with a high burden of bacteria. And that this differs from children who most often have possibacillary TB disease. Most are non-infectious, are smear, culture, and PCR negative, and that they are diagnosed clinically based on symptoms and then their radiograph, which often shows intrathoracic adenopathy rather than cavitary TB. Now, young children can suffer from really significant tuberculosis findings on chest radiograph in addition to miliary pattern, but most children of older ages have this type of clinical manifestation. So that's why measuring TB epidemiology in children is actually quite difficult. It's easier to measure TB in adolescents. So that transitions nicely into the statistics that we have to review today on the TB epidemiology worldwide. Most of the statistics that I'm going to provide today are provided here in the Global Tuberculosis Report, which is available here via the QR code. And the WHO reports annual estimates of global TB, both incidence and prevalence, in addition to mortality. And that they report what's reported to them, so regional and country level data. And that 22 countries out of 195 report data. So keep that in mind, that the data is actually a paucity of data compared to the total number of countries that are in the world. And that 10 countries in Africa report data out of 54. They do actually now provide age and gender specific data, but no specific statistics in pregnant patients, and they don't age stratify in young children. Since 2012, however, they have disaggregated data by age. So they categorize adolescents as adults, as being those greater than or equal to 15 years of age. And then children are those 0 to 14 years of age. But their inclusion of child cases is limited because it's hard to find the child cases in the communities. That there's a limited focus on non-infectious tuberculosis. But WHO is trying to make headway and trying to identify those children who are at increased risk, including increasing surveillance, identification, and reporting of those at high risk through contact investigations, and then trying to focus on development of enhanced diagnostics. In order to enhance childhood TB estimates worldwide, however, we'll have to have improved health infrastructure and integrate TB screening in child and maternal health services, have increased funding for these contact investigations, including young children of those living with a TB case, and then promote case-based and age-specific data. So thankfully, the WHO has made a lot of progress since 2012 when they started to focus on child and maternal health. But then COVID-19 hit, and all of this progress was made, and then unfortunately, there was a huge diversion of resources, as you know, and that the poverty mitigation techniques that have occurred across the world, unfortunately, have been stagnated by the COVID-19 pandemic. That the COVID-19 pandemic progress has been reversed, unfortunately. For the first time in 2020, that TB deaths have increased for the first time in over a decade. Fewer TB were diagnosed and treated or provided with TB preventive treatment, and that fewer resources for essential services and research and development have been diverted to tuberculosis. And I think this is a really striking comment, so I'm going to read it out loud from the WHO General Director. Ending this debilitating disease remains a priority for the WHO, and in recent years, we've made encouraging progress globally. But the COVID-19 pandemic has put these gains at risk. Not only does the virus pose an increased risk to people with TB, it has also caused severe disruption to services. I want to remind you that the struggle to end TB is not just a struggle against a single disease. It's also a struggle to end poverty, inequity, unsafe housing, discrimination and stigma, and to extend social protection and universal health coverage. If a pandemic has taught us anything, it is that health is a human right, not a luxury for those who can afford it. With solidarity, determination, and equitable use of tools, we will defeat COVID-19, and with the same solidarity, determination, and equitable use of tools, we can end tuberculosis. So as that WHO comments, the WHO director commented on the difficulties that we have, the WHO remains committed to end tuberculosis, and that comes with data. So now we have these new data that we have to work from. So TB funding dropped from 5.8 billion to 5.3 billion from 2019 to 2020, which is less than 50% of what's needed. And that shortfalls have actually occurred both in monetary, but also human resources. So there's been a reduction in TB cases detected and reported. And then there's been a supply and demand disruption, both in diagnostic and treatment services for tuberculosis. So we have a new baseline that we have to move forward from. These were some of the targets that the WHO wanted by 2020 to have 13 billion annually dedicated towards TB prevention, diagnosis, and treatment and care, and that they only met 5.3 billion. And that TB research, they wanted 2 billion annually, and they met a target of 109 million. How about prevention in children? So when we think about those household contact investigations, which were so important, as I highlighted earlier, that their target was to try to identify 4 million children less than 5 years of age by 2020, and that they identified 29% of their target. And that those who are older, unfortunately, they only identified 1.6% of their target. And so as you can see in this figure, from 2019 to 2020, the global number of people provided with TB preventive treatment decreased in all of those who were at high risk. So all people living with HIV, that there was a drop, those contacts under age 5, that there was a drop, and then contacts aged over 5 as well. There was a drop from 2019 to 2020. But I think if we look at here, that there was some substantial progress made within these time periods. So I'm hopeful with renewed focus that we can get back to those places again. The other major aspect of prevention in children and young babies is the administration of BCG vaccine. And unfortunately, COVID-19 led to a 5% reduction in coverage due to funding as well. For those of you who are interested, this is a neat resource called the BCG World Atlas. It's available here via that QR code. The BCG World Atlas provides a country-level profile of where the BCG is administered, which BCG strain is given, in addition to the number of doses and age of doses provided by country. So what about TB incidence worldwide? So the WHO target for 2020 was to decrease TB incidence across the world by 20%, and that by 2020, they met 11% of that target. The COVID-19 pandemic, as I mentioned, decreased the number of people detected to have tuberculosis. So there was an 18% reduction in TB reporting from 2019 to 2020, from 7.1 million people newly diagnosed with tuberculosis to 5.8 million incident cases in 2020. The 16 countries with the largest contribution of the global shortfall in TB medications include India, Indonesia, and Philippines. And this isn't because people are not suffering from tuberculosis in the countries. Unfortunately, it's because of diversion of resources. And so that we're missing all of those cases that were previously diagnosed because of COVID-19 diversion of resources. And that it didn't just affect India and the Southeast region, but all the regions that were covered by the WHO had a dramatic decrease in the number of new cases diagnosed and reported to the WHO by region from 2019 to 2020. So in 2020, there were 9.9 million new cases, that 30 of the high burden country provided 86% of the incident cases for a case rate of 127 per 100,000 population. And that most of the new cases were reported in Southeast Asia, Africa, and the Western Pacific. This graphical actually shows the estimated TB incidence in 2020 for countries with at least 100,000 incidence cases, and that these 8 countries ranked that accounted for 2/3 of the global cases. So India, China, Indonesia, Philippines, and Pakistan. And the WHO also reported what was reported in that Nature magazine, that the association of a low GDP was inversely correlated with the incidence of disease in that country. So poverty was a huge driving factor in TB incident cases. And that this shows the estimated TB incidence by country in 2020, and that those countries that had the highest incidence were actually highlighted in the darkest teal here. And that the report actually highlights Central African Republic, actually the Democratic Republic of Korea, Lesotho, Philippines, and South Africa having some of the highest estimate of TB incidence rates. So there's a paucity of the data that's provided on children and women, but this is one of the graphics that actually provides estimates of TB incidence in these populations. So the highest burden of new TB cases actually occurred in adult males. They accounted for 56% of incident cases, compared to 33% of women, and then 11% of children, which accounted for 1.1 million cases in 2020. A similar incidence was actually calculated in 2014 when a mathematical model was actually published, and that they approximated that approximately 1 million children have newly diagnosed tuberculosis around the world every year, which accounted for 10% of cases. About 32,000 of those children actually are diagnosed with multi-drug resistant tuberculosis, and it's approximated that 53 million children have TB infection. The WHO said that they think that the MDR and rifampin-resistant TB incidence worldwide is stable, that still accounts for 3 to 4% of new infections, and that in those who were previously treated, that 18 to 21% have new diagnosis of MDR or rifampin-resistant TB, and that the highest proportion of these cases actually occurred in the former Soviet Union. So the data is actually quite sparse in children, and that this was one publication that was published in the Lancet Infectious Diseases in 2016 that also provided a mathematical model of the global burden of drug-resistant tuberculosis in children, and that they used the WHO Global Project Drug Resistance Surveillance data from 1988 to 2014. This is how they divided the patients into drug-resistant cohorts. So INH monoresistance, rifampin resistance, and then MDR, TB, and XDR tuberculosis. So in 2014, they found that approximately 7% of children had INH resistance and that 3% had MDR TB. Of those with MDR TB, about 5% had XDR tuberculosis. And that the incidence was estimated at 847,000 resistant cases, and that 25,000 were multi-drug resistant. And that the highest proportion of incident cases actually occurred in the African region, in addition to Southeast Asia. And that this cartogram shows the total incidence of MDR tuberculosis. So the highest incidence is actually happening in those countries in the former Soviet Union, as highlighted here. The paper also commented that they think that actually more than was actually previously estimated of children are actually infected with a drug-resistant strain. So 67 million children are infected, that 2 million of those have MDR and 101 have XDR tuberculosis, and that many children go undiagnosed, and that they're at risk of developing drug-resistant TB later in childhood or in adulthood. And unfortunately, identifying these children has also been reduced from 2019 to 2020. So the global number of people reported to have been enrolled in treatment for MDR-TB, the adults are actually here in blue and the children are in red. And as you can see, the proportion also decreased in children being identified. And the target of trying to identify at least 115,000 of these children who needed treatment for MDR tuberculosis, that they only made 11% of that target by 2020. So what about the children in the United States? This is just an overview from the MWR and providing statistics on the tuberculosis disease counts and incidence by patient birth in the United States. And so as you can see, there's a downward trend of incidence up until 2020 when there's a slight uptrend as well. And this probably is related to COVID-19 as well. And that the US traditionally has had a disproportionate number of incident cases in persons who are non-US born compared to those who are US born. And that has been detected throughout this time period, 10-year time period. So what has happened in children? There was a neat study that was recently published in the Lancet Public Health on the epidemiology of TB among children and adolescents in the US from 2007 to 17, an analysis of the national surveillance data that was provided to the CDC. They identified 5,175 children with TB disease in that time period, which was 8% of total cases detected in the United States in that same time period. And of those that were detected, 68% were actually US born. And of those that were US born who developed TB disease, most were less than the age of 15, and that most were actually 1 to 4 years of age. Of those who are non-US born, actually most cases happened in older children, including those who are considered adolescents. So what about race, ethnicity, and their contributions? So of those who are US born, those who have Hispanic race ethnicity were of the highest proportion of TB disease cases in the United States. And among the non-US born population, the highest proportion of cases actually had Asian ethnicity or Black race. And what about the location where the parents were born? So a previous publication actually found that of children who had TB disease, that 75% of them had some type of contact, either foreign-born, non-US born contact, either parent or travel or birth outside the United States. So this study actually found a similar correlation in non-US born parents. So of those who had TB disease, that 41% had both parents who were non-US born, and that of those who are non-US born, that 57% had both parents who are non-US born as well. And that what the study also interestingly found is that children who are US born are most often picked up via contact investigation rather than TB symptoms. And then those who are non-US born are actually picked up more likely because they develop tuberculosis symptoms. And so how are these children identified? So 66% were actually identified through contact tracing or because of birth outside the United States or because of extended travel or living outside the United States. But 21%, their only identified risk factor was actually birth outside the United States, and that the highest burden was actually in those that were less than 1. 13% overall actually had no identified risk factor identified. So how did they manifest? Most manifest with pulmonary tuberculosis or were diagnosed with pulmonary TB. So 68% had pulmonary tuberculosis, 22% had extrapulmonary tuberculosis, and that of those, 39% were actually culture confirmed. 8% had monoisoniazid resistance, and then few had rifampin resistance or MDR-TB. 80% had an abnormal chest X-ray, and that 91% completed treatment. Very few were HIV positive or died from complications from TB. And so they calculated overall incidence of pediatric tuberculosis in the United States as 1 case per 100,000 person years, and that the highest incidence was in those less than a year, followed by those in adolescents. And the age-specific incidence was 10 times that in those who are non-US born. So where were the parents from? So the parents of those who developed TB disease when they were non-US born were actually most often from Mexico, Guatemala, or the Philippines. And then the children who were non-US born who developed TB disease were more often from Myanmar, Malaysia, and Ethiopia. But there's a whole splay of the countries that are listed here. So that transitions into TB mortality. So the WHO and TB strategy in 2020 that they wanted a target of 35% reduction in the number of TB associated deaths by 2020, and they met 9.2% of that target. So what's happened since the COVID-19 pandemic? As I mentioned earlier, this is the first time in 10 years that TB deaths have actually increased. So as you can see that there's a downward trend, and then an increase in all of these populations, both the total HIV negative and HIV positive. And then as you can see, there's actually a continued downward trend in the associated mortality of HIV deaths, but that there's an increase in TB associated death in both HIV and HIV positive and HIV negative individuals. And that TB is the second leading infectious cause of death, secondary to COVID-19. That 1.3 million TB deaths occurred in 2020, up from 1.2 in 2019. Of those who are HIV positive, 214,000 cases occurred, people died from TB, up from 209,000. And that the TB deaths increased in most of the 30 high burden TB countries. 85% of the TB associated deaths occurred in African and the Southeast Asian countries. And that India itself accounted for 38% of global TB deaths in those who are HIV negative. And among the HIV negative, we have some age-specific and gender-specific data that 32% of women accounted for those deaths and 16% of children. And then of those who are HIV positive, 40% were women and about 10% were children. These were the trends that were estimated in the absolute number of TB deaths. And as you can see, it actually occurred in all of the regions throughout the world, not just Southeast Asia. And that the COVID-19 pandemic had a huge impact in all of the countries, including from Angola to Kenya to the Philippines to Vietnam and Ukraine. So what about in children? As I noted in the prior studies, we often go based on mathematical modeling of estimates of the data that's actually provided by countries. So this was an estimate from 2014. The total deaths were 136,000 deaths in that year, and 81,000 occurred in HIV negative children, which accounted for 7% of the total deaths from tuberculosis, for a case fatality rate of around 14%. So to end with, not only do we have a paucity of data in children, but a huge paucity of data, unfortunately, in pregnant patients. And that pregnancy is something we definitely need to have a renewed focus on, because the risk of tuberculosis in pregnancy not only has an increased risk for the mother, but also for the child. And the mother's at increased risk because of the immune state of the mother during pregnancy. And then to the child, there's a 2 times increased risk of premature birth, low birth weight, and IUGR. And there's a 6 times risk in perinatal death, especially in HIV co-infection. And the risk of transmission to the infants is highest in the early postpartum time period, when it's described as a very vulnerable time, when there's a 2 times risk of them developing tuberculosis. In a South African study of pregnant women who had active tuberculosis, that 15% of their infants were infected within 3 weeks of delivery. So the true burden of tuberculosis in pregnant patients worldwide is unknown. There was a publication in 2014 in Lancet Global Health that provided an estimate of the global burden of tuberculosis disease in this population, and that they used a mathematical model to try to estimate the prevalence of tuberculosis in pregnant women worldwide. They identified what they felt like was an estimate of 216,500 pregnant patients with tuberculosis in 2011, and that the highest percentage occurred in the African region, followed by the Southeast region. And that the highest rate, as you can see, a very high rate in Afghanistan, so 7.2 per 1,000 pregnant women, and then up to 10.3 in South Africa, also very high in Zimbabwe. But that the percentage of global burden of tuberculosis women was highest in India. So in conclusion, making improvements towards TB elimination, it's important that we redirect resources towards TB prevention and treatment. That enhanced TB screening at the household level is especially important, especially among those less than 5 years of age, and those that must be identified through enhanced contact tracing. And we must be committed to providing BCG vaccination to infants. We also want to increase the treatment of those with TB infection, which is going to be discussed in future webinars, and the use of shorter regimens to be able to complete the treatment faster. And I go back to this, I'm committed to ending tuberculosis as well. And I think a renewed focus on trying to identify those who are most vulnerable, including children and pregnant patients, is of utmost importance in order to eliminate tuberculosis worldwide. I do want to provide another resource for you all. So there is an app that's available for download that actually has these global TB statistics, which you guys can monitor over time and see what happens over time. I've downloaded it myself, and I think it's a very user-friendly and easy app to use. That's all I have. Delphina, do we have time for a break, or do you want to go into the case discussion?
I think we should go right into the case discussion and panel discussion.
Okay, sounds great. Are the panelists here? So Dr. Stark and Dr. Seaworth, and I heard, and Dr. Smith potentially are going to be our expert panelists on the cases. Looks like they're both here. Dr. Stark. Yes. Okay, great. Cool. Okay.
Okay, they're unmuting. Okay.
Okay. Oh, they're all three here. Great. Thank you for coming. All right, so the first clinical case is actually a family cohort of over 7 people. These are refugees from Afghanistan who were urgently evacuated. They arrived to the United States in early 2022. The mom, the father, who was pregnant at the time of her arrival to the United States, and 5 children came. So a 2-year-old, 3-year-old, 5-year-old, 8-year-old, and 9-year-old. And again, mom was pregnant. And they had overseas pre-immigration screening that was not available. The family was, and they didn't know about their pre-immigration screening either. And the family was tested for TB upon arrival to the United States. So what do we think about tuberculosis in Afghanistan? Do any of the panelists want to comment on what's happening with TB in Afghanistan? I have a few slides to share, but I want to just hear your thoughts on it.
Hey, Dr. Stark, are you available? I think we might be having some technical difficulties. Give us just 1 second.
Okay. I can move forward too. So as you guys know, thousands of Afghans were forced to leave their homes this year as fighting intensified in the country. And so as you can see, the number of people displaced by conflict by month dramatically increased, with a dramatic increase in 2020 at the end of 2021. And that a lot of families were displaced into camps, and that family happened to be urgently evacuated, but a lot still remain there. And that TB in Afghanistan remains a major health problem. Unfortunately, we have a lack of recent statistics because of the health infrastructure disruption. But in 2016, there were 65,000 cases that were reported and 11,000 deaths. And that this was decreased from prior. But that one of the estimates that I saw is that there's supposed to be 600,000 cases detected in 2021, which may be due to the COVID pandemic, but also significant disruptions in the health infrastructure. So as this World Bank graph shows, that there's a dramatic increase in the tuberculosis burden in the country of Afghanistan. So that we considered this family to be at high risk of having tuberculosis. And that poverty, unfortunately, it has exacerbated that problem. And that this was a publication that highlighted the forgotten that tuberculosis amidst the humanitarian crisis in 2019. So upon arrival, the dad was asymptomatic, had a normal chest radiograph, but a positive IGRAF, and that he was started on 3-HP. Mom was asymptomatic, and that she also had a positive IGRAF, but it was done at the end of pregnancy. Her chest x-ray showed a right upper lobe calcification, but was otherwise normal. So I'm going to open it up to the panelists. What do you think about the management of TB infection, or are you concerned about the chest radiograph in the mother? And that would you manage her differently following delivery versus during the pregnancy?
So I'm sorry, we're trying to figure out some technical difficulties with Dr. Stark's microphone.
Oh, okay.
Dr. Geltmeyer, Dr. Smith, and Dr. Seaworth, please feel free to jump in.
I'm sorry, Lindsay. Did you show an X-ray or just describe it?
No, I just described it, that she has this right upper lobe calcification, but it was otherwise normal. So she doesn't have a consolidation and she's asymptomatic.
So if I were seeing this woman in clinic, and I guess because I see a lot of adults, my first step would be trying to view the X-ray myself, because often the people that are reading them aren't really looking for the subtle abnormalities that might make me very worried about active disease on an X-ray. So if I were convinced that it was definitely old disease, not active tuberculosis, I'd probably get some sputum smears just to be sure. I would favor treating this woman for latent TB infection during pregnancy. She has been under considerable stress. Pregnancy is a time of when progression to active disease certainly is more likely, more common, especially at the end of pregnancy. And I think she's at high risk and would include her in the group of high risk individuals that should be treated even if they are pregnant for latent TB infection.
Okay.
I hope that was your question.
Yeah, that's great. And I'm sure people will be get this information in a future webinar, but what about which regimen would you choose? Which regimen is most safe for her to receive towards the end of pregnancy, or are they all?
My preference would be to use rifampin. The risk of rifampin resistance in Afghanistan and any country in the world is certainly much less than the risk of INH resistance, which is at least 10% globally, probably higher in some areas like Afghanistan. Rifampin is safe in pregnancy. It's my go-to drug in pregnancy. I've used it a number of times for treatment of latent TB infection and many times for treatment of active disease. So I would give 4 months of rifampin. 3-HP is not yet approved for use in pregnancy.
Okay. And is it safe for breastfeeding women to also receive
Yes,
following delivery?
absolutely.
Great. Dr. Stark, were you able to get your microphone working? Did you have?
Can you hear me?
We can. Yes, great.
Okay,
Welcome.
Cool. Okay. So I have to admit, I haven't been concentrating because I've been trying to get my microphone working. So,
Okay.
but let me ask you a question. So there's been a controversy for a long time about treating pregnant women for tuberculosis infection, not for TB disease. There's no controversy there. And I'm curious what Barbara thinks about that. You know, traditionally we've said we should wait till after the first trimester because of concerns, theoretical mostly, about teratogenic effects on the baby. But I wonder what Barbara thinks now about treating women during pregnancy as opposed to waiting until after delivery. I know in the US we've had all kinds of logistical problems because the healthcare system that cares for pregnant women tends to be different than the one that takes care of women after the baby is born. So Barbara, what do you think?
I think it's reasonable to treat women during pregnancy. I tend not to treat them in the very early weeks of their pregnancy just because many of them are nauseated already, and it just trying to take a medicine sort of makes them unwilling to take it later because they associate the medication itself with nausea rather than it being related to the nausea of pregnancy. So I usually will wait until about 12 weeks and then I am comfortable definitely with starting treatment for any woman who has an increased risk of progression to disease or increased risk of having been exposed during the previous several years, or has a lot of stress, which would apply to any individual coming to a new country as an immigrant, whether that's a refugee. These women are even more impacted with the stress and the move to the US, but any new person to a new country has some stress. We find that many of these women, by the time they come back to us for their postpartum visit, are pregnant again. And in fact, this absolutely happened to a pregnant woman that was from Afghanistan. She was deferred. She was pregnant by, she was seen in the refugee clinic. And then when she came to us, we tested her and she was pregnant again. And then she was so nauseated, we weren't able to get her medications in. And then she sort of developed a psychological intolerance to them. And unfortunately, at week 16, had fetal demise. And I believe we inadequately treated what was likely progression to active disease there, but I'm not sure. She was really never able to tolerate her medication.
Yeah, I agree with you. Lindsay, you mind if I say a few things about breastfeeding?
Sure, but I also want to just highlight this woman was under an extreme amount of stress. Not only were they evacuated from Afghanistan, which was an extreme turmoil, she also was evacuated with her 5 children. And I'm a mom of 1, and that's stressful enough for me, but I can't even imagine the situation she was in. So very high risk, I think.
And you know, some of the historical data, we know that stress tends to make TB infection progress to TB disease. And there's historical data about TB in foreign-born individuals within the US that a very high proportion of them occur within the first several years after coming to the US. It's thought that there were 2 major reasons for that. Number one, they actually already had TB disease and still got through the immigration process. And this was back some years ago. And second, that the stress of immigration, exactly what you said, and so forth, and dealing with new health system actually may have increased the likelihood of reactivation of the organism. For breastfeeding, so there is extremely little data about TB drugs and breastfeeding, very, very little data. And the only study that I'm really aware of was done quite a while ago, and Dixie Snyder reported on this. And they found that the amount of INH in particular, and to some extent rifampin in breast milk was, it gave the baby at most about 10% of the serum level as would be expected if you were actually treating the baby. Now, one thing about INH is that little babies are very sensitive to pyridoxine deficiency. And we know that breast milk is relatively poor in pyridoxine. If a baby is taking isoniazid and is breastfeeding, it is crucial that that baby receives supplemental pyridoxine, either separately or as part of multivitamins. That's okay too. There's less information known about the risk to the baby if the mother is taking INH, but the baby is not, and the baby's breastfeeding. Probably it's not a very big issue, and those babies are not routinely put on pyridoxine, and they don't seem to have trouble. The problem, of course, with acute pyridoxine deficiency, it can be seizures, and little babies who are taking isoniazid and not given pyridoxine and they're breastfeeding can present with metabolic seizures. So there's really pretty much no contraindication to breastfeeding when a mother is being treated for tuberculosis infection with any of the drugs that we would normally use.
Thank you. Thank you for that discussion, both of you. So moving forward, mom was actually, as Dr. Seaworth mentioned, investigated for TB disease. So even though she was asymptomatic, they did collect sputa in the field that were all smear and NAT negative, and then the cultures were negative by the time we saw her. And she had not been started on treatment. So at this point, Dr. Seaworth, if you look at the chest x-ray and there is an old calcification there, she has negative cultures at 4 weeks, would you treat her for TB infection? She is breastfeeding her infant.
So it's at 4 weeks, you're at 4 weeks now with the cultures?
Yeah, 4 weeks old. Or would you wait for finalization of the cultures?
The guidance would say that you wait for finalization.
Yeah.
Nearly, I would say about 80–90% of cultures, if they're going to be positive, are positive at week 4. But in somebody like this, it might be a late positive culture.
Right, great. So she may actually need disease treatment. And so giving her treatment for infection prior to finalization would be advice. Fantastic.
Lindsay, there's a go ahead. I'm sorry. There's a question in the Q&A maybe we can address after this.
At the end, yeah, the Q&A.
This whole thing,
Yeah. Yep, I saw that too. So there are a lot of children now. This infant is 2 months old. So the question is whether or not they should all be treated for infection, and if so, why? Or maybe they have disease, right? So all these kids are at high risk. Neither of the adults in their close proximity are thought to have TB disease, but how were they evaluated? So the 2-month-old was asymptomatic and had not had a test of infection to date due to the age, in addition to not having access to regular pediatricians. So had not seen a pediatrician yet since delivery at the hospital. And then the 2, the 3, the 5, the 8, and 9-year-olds were thought to be all asymptomatic, but that they all had tests of infection and they were all positive.
Lindsay, what was the BCG vaccination status of the kids, including the 2-year-old? I'm sorry, the 2-month-old.
The 2-month-old wasn't vaccinated because it was born in the United States, but
Okay.
the rest had received BCG vaccines.
Yeah, and just to make the comment about, the false positive results with tuberculin skin testing in kids who've had BCG vaccine. And again, we're starting to do IGRAs in younger and younger kids. And if it were me and the 2-month-old, I would have no hesitation to do an IGRA. There's no problem doing a TB skin test. If the 2-month-old had BCG, I would definitely not do a TB skin test. I would do an IGRA instead.
And just because of cross-reactivity, correct?
Absolutely, false
And then-
positive result.
Perfect. And then the IGRA is helpful if positive, but if not positive, not helpful necessarily. Is that what you mean in the 2-month-old?
No, I don't mean that. I mean, if they're young, healthy children, if
Yeah.
they really are infected with M. tuberculosis, they should respond to
immune
an
response.
IGRA.
Yep.
So the negative predictive value should be fairly good also, unless they've been recently infected. And that's always the problem, of course, is
Right.
anytime during the immigration process, including after their initial screening, these kids, I mean, they're subjected to risks even after they go through the panel physician investigations, because sometimes there can be a delay of months between
Right.
the time they're looked at and then they actually get to us. So that has to be taken into account also.
And as you mentioned, that their risk period actually extends a long time after they immigrate. So that these kids are at high risk of infection progressing disease at any point in time, for sure.
Yep.
So Lindsay, I might
Yeah.
ask if anybody else immigrated with this family, a grandmother or uncle or aunt that hasn't yet been tested, or if they moved into the home of somebody who had not been tested. So I want to
Good
know
question.
that as well.
Not that we knew of. But that's a very good question that this family was brought from Afghanistan together, and that I don't think anyone else came with them, but I actually don't know that information.
Do you mind if I make another comment? So
Yeah.
in a place like Houston, where we're now receiving a lot of immigrants from one place, it happens to be Afghanistan now, but it's been other places. There is a tendency for folks when they settle here to settle in proximity to each other. And in fact, sometimes even in, say, the same apartment complex. And so we have actually historically had issues. We've actually come to know certain addresses because unfortunately there have been people who either weren't tested or refused treatment or something else and then developed TB. So again, these folks often are in a somewhat increased environment for even getting de novo infection after coming to the United States, not just before they come to the United States.
Yeah. Great. So the children were all evaluated by their pediatrician, and then when we saw them at the TB clinic, we did everything over again and then added chest radiographs. So the 2-month-old remained asymptomatic, still hadn't had a test of infection, had a normal exam and a normal chest radiograph. The 2-year-old was also asymptomatic, again, had the positive IGRA, normal exam and normal x-ray, and the same with the older kids. So Dr. Stark, Dr. Smith, Dr. Seaworth, when do we do a test of infection in the 2-month-old? You said now, right? Is that true, Dr. Stark?
Yeah, I wouldn't put it this way. I wouldn't hesitate to do it now. The issue then becomes, does it need to be repeated because of the timing of what we think may have been an exposure? You know, in this case, this kid was born in the United States, so the risk should be substantially lower than if the child was born in Afghanistan. And so there's several different questions here. Question number one is, well, can a child immunologically, does the child have the immunologic machinery to react to a TB skin test or to an IGRA? And the truth is they pretty much do. Historically, the problem hasn't been with T cells or anything. The problem has been with the macrophages that actually create the inflammation that we interpret as being a positive tuberculin skin test. That's not an issue with the IGRAs, and that's one of the theoretical reasons why the IGRAs may even be a little bit better than the TB skin test in this situation. And then the question of whether the child would need to be retested at some point in time depends upon the timing of when you think the child likely could have been exposed to a case, and you need more time to let the reaction turn positive.
Okay.
I hope I'm being clear. It's two
Sure.
different concepts related to the very, very young age child.
Yeah. So there is an extra question in the chat from Lisa Martinez that says, if a TST was done and came out positive, can you do an IGRA, and how soon would you do it? And so for the young infants, that if the TST was positive, he's not BCG immunized, so likely indicative of infection. And so that I wouldn't do an IGRA to follow it up. In the older kids who were BCG immunized in Afghanistan, and they had positive, especially the 2-year-old, the younger kids, that it's possible that there was a TST that was falsely positive because of cross-reactivity with the BCG vaccine. Although because the incidence in Afghanistan is so high, that doing an IGRA to confirm TB infection can be done at any time. And I hope that answered your question. So, and then the recommended treatment. So for the 2-month-old, Dr. Stark, would you start treatment for TB exposure?
Well, this is where it gets really, really complicated, because this particular child was born in the US. As far as we know, this child has not been exposed to a person with contagious tuberculosis. So at least theoretically, this child shouldn't need treatment. Now, there are certainly people who say, well, look, everybody else in the family is positive. We don't know exactly when it happened.
Right.
And so let's just be careful. The medications are usually really well tolerated by 2-month-olds. Let's go ahead and treat this kid until we can be a little bit more confident of what the meaning of a negative test of infection. I would probably not treat this child, but there are some people who would, and that's the rationale.
Yeah. And Dr. Seaworth had a really good question about potential other contact, right? A grandparent or an aunt, uncle
Right.
potentially traveled with them too. So, especially because the parents don't seem to be the ones that actually have TB. And then the 2-year-old, if has infection, so we have 3 current regimens, although rifampin is on shortage. So we have INH for 9 months daily, rifampin for 4 months daily, and then 3-HP. The studies actually show that we can do 3-HP down to 2 years of age. But what's your experience with using rifampin versus 3-HP versus an INH in a 2-year-old?
Well, the problem in the United States is that we do not have any pediatric formulations for any of the drugs. We do have INH suspension, but once a child gets above 5 kilograms, the amount of volume that they have to take, it's got sorbitol in it, and they often develop GI distress and diarrhea. So I find actually that the pill burden, the physical difficulty of the treatment for kids really less than 5, but particularly at age 2, is really tough. So the vast majority of the time, I'm going to treat this kid with 4 months of rifampin if it's available, or 9 months of isoniazid if it's not.
Yeah, great. Dr. Smith, were you going to mention something?
Yes, I was going to say the same. I would definitely treat this child, and rifampin would be the treatment I'd choice.
If we have it, right?
Yes.
Yeah. Okay, great. And then the older kids that we can hopefully treat, although the 3-year-old may not tolerate 3-HP as well. So this is what happened, that the PPD wasn't placed yet.
Lindsay, do you mind if I mention something else? There
Yeah.
actually is a 4th regimen, and that's
Yeah,
3
right.
months of daily isoniazid and rifampin, which is actually the same thing as 3-HP, except it has to be given daily because of the short half-life of rifampin. And that is an alternative. It's used quite extensively in Europe, not so much in the United States, but that would be a regimen that could be used either certainly for the 2-year-old or 3-year-old if they couldn't tolerate 3-HP.
Yeah, right. You're totally right. I'm sorry for forgetting that as well. Okay, so I actually excluded the 9-year-old. What happened with the 9-year-old? So the 9-year-old was brought in with the other family cohort. Dr. Stark actually see this patient, and the interview was done with a Pashto interpreter with the mom, and that she said that there was no one that she knew of that had tuberculosis, and that this 9-year-old, since he was seen in the immigration clinic, actually that she was concerned about him, that he felt warm, had night sweats, had no cough, no change in activity, but had lost some weight. So he had decreased by his weight by 2 pounds, and by 7%. He looked small and it was thin on an age. He had actually no BCG scar, even though mom thought he got the BCG vaccine, and that had a normal pulmonary exam. But his chest X-ray was not normal. They thought that he had a right apical opacity and small right pleural effusion. So how should he be managed? This is concerning, right?
Definitely. So with an abnormal chest X-ray, a positive IGRA, he should be treated for disease.
Yeah, good. And how would you evaluate him for disease? Since you don't have anyone known in the household or the community, what would you do?
Well, you can try to get sputums, or you can get gastric aspirates. I think in a 9-year-old, you ought to be able to get sputums.
Perfect. So he was tested for HIV and negative, and that cultures and molecular testing was obtained in the field. He had negative smears, but a positive NAT. Very interesting, especially given the chest X-ray findings. I don't know if you were shocked by this, Dr. Stark, but I definitely was. And he was
Nothing shocks me anymore.
Nothing shocks you anymore. Yeah. And he was started on right therapy. And at 2 months, he actually had improvements in his symptoms, so resolution of his fever and night sweats, and he had increased by 2 kilos actually, and was found to have a pan-susceptible isolate. And so his PZA and ethambutol were discontinued, and he was continued on daily INH and rifampin. I actually have 2 more cases, and happy to go through one if we have time, but just wanted to open up to any thoughts or from the panelists before we move forward.
You want to look at the QA just for a break?
Sure. I only see 3 in there. So Lisa Martinez just responded. And then there was one question about why is TB increased in males worldwide?
They're out and about more.
So hi, everyone. This is Delphina. So I do have some questions that came in from the applicants during registration.
Oh,
so I
okay.
can bring those up if you'd like to address a few of those.
Can I just reply to the increased number in males?
Yeah, sure.
I think certainly men are interacting with individuals out in the world more than women, but I think also women are probably undercounted. They may have less access to healthcare. Women I have taken care of who come from a variety of places really feel the stigma of TB, I think even much more acutely than their male counterparts. They feel they're not useful to their homes and their husbands and their families anymore. And I think are reluctant actually in some ways to seek care. They're much more reluctant to cough up a big goober and give you a good sputum specimen. So I think there's some of that. And I think if we really looked at numbers, that some of the exposure they have in homes with the different ways that they cook and the smoke fires, etc., that if everything were fair, I bet that disparity between men and women and the incidence of TB might be more similar. That's just my thought. Sorry.
No, I agree with you, Dr. Seaworth. I think that the literature kind of supports that too, that men tend to be more health seeking and that there's a lot of stigma associated with women seeking healthcare for TB too. Yeah.
And if I could add a couple comments. So historical data has shown that children are more likely to get TB if it's the mother that has TB than the father. And I think it's really the inverse of what was just said. They're around their mother a lot more when the father is outside the home a lot more. And so if the mom has TB, it's a particular risk. The other thing I think we all also should emphasize is among adolescent girls have at least the same incidence of TB, if not a little bit higher than adolescent boys.
Yeah.
We don't know why this is. Something about hormonal milieu, could it be behavioral? We don't know. But it's been a pretty consistent observation across various populations of humans around the world. And it's an interesting thing that's really terribly understudied.
Yeah.
Matter of fact, I would argue adolescent TB also, as with TB in women, is also underdiagnosed or diagnosed late for a variety of reasons.
Yeah, thank you for mentioning that. In that paper that I mentioned that was published in 2004 on the epidemiology of pediatric TB and TB in children in the pre-chemotherapy era, that adolescent females were at the highest risk of actually dying from TB after those who were less than 1 year of age. So they were second highest risk in dying from tuberculosis in that population. Very interesting.
Wow.
Delphina, we are happy to do what you would like. I can do the final case and then we can do Q&A, or we can do Q&A now. We have 15 minutes. Oh, it's only 1:45. We have till 2:30, correct?
Yes,
Should
that
I
is
do
correct.
I'll do another case. How about that?
Yes.
Okay,
sounds
great.
good.
So this was another really interesting case. This is a 6-year-old male who was from Guatemala. He was BCG immunized and he arrived to Houston with his father in July of 2021. Father came to work for a construction company, and that he said that he was going to be there for 3 years. And mom and his 2 siblings remain in rural Guatemala. And the father speaks Quichua and some Spanish, and the child only spoke the Guatemalan dialect of Quichua. So we couldn't actually get an interpreter that spoke this dialect. And so we could not communicate with the little boy at the time of the initial interaction. And so could only speak with the father. And that he had developed a soft tissue swelling in the right paraspinal region in December of 2021, had no fevers or systemic symptoms. And he was seen by his PCP. And at that time had a quantiferon that was drawn. It was 0.87 and 0.35. As a reminder, the cutoff of positivity is 0.35 on the quantiferon. So he was referred to dermatology, I don't know why, but also to the TB clinic because of the positive quantiferon. So what do we know about TB in Guatemala? I don't know if any of the panelists know about TB in Guatemala. I have a little bit of information. And then what the difference is between rural and urban areas. So what I found was that there's a little bit of paucity of data, but that the WHO actually reports an incidence of 25 cases per 100,000, so not considered a high burden region. And that around 5,000 cases were reported in 2020, and that 530 of those were children, and that there were 410 TB associated deaths. But it's likely underestimated, and it's thought to be of higher burden of TB disease in rural Guatemala compared to urban Guatemala. And that there was an interesting case report that was published in the Journal of BMJ Case Reports in 2017 that actually described a male from rural Guatemala, a 23-year-old indigenous Guatemalan male, who had 10 months of symptoms and progressed to have really significant neck swelling and was found to have extrapulmonary tuberculosis. And that this case report actually highlighted the discrepancy between case detection in rural areas of Guatemala compared to urban areas of Guatemala, and that many of the indigenous populations also have a stigma that's associated with seeking actually healthcare within the sectors, and that they go to a lot of community healers and don't seek care. And that unfortunately, the health infrastructure is also pretty poor, meaning they don't have as great access to once they get really, really sick. And so they present often with extrapulmonary tuberculosis or really severe pulmonary TB, kind of late onset. So this was a picture of our case. He was super interesting. He was a febrile on arrival, had a normal respiratory rates, but he was underweight, so less than 3rd percentile. And he was actually less than 3rd percentile for height. The problem that we had was that we didn't know his exact age because we didn't have his birth certificate. But based on what his dad told us his age was, this is where he fit on the growth chart. He had poor dentition on exam, had a murmur auscultated on exam, and had decreased breath sounds over that swelling. Had no hepatosplenomegaly, and had the back swelling was actually non-tender. So when you pushed on it, it wasn't tender at all. And as you can see, there's no overlying erythema. And this was his chest X-ray that showed what looked like an opacification and then a small pleural effusion in that region. And this was the lateral chest radiograph. And then as you can see here is where the posterior, pretty significant back swelling was. So how should he be managed? Are we worried about tuberculosis?
Yes.
I mean, this is a talk on tuberculosis, right? It's such an interesting manifestation. Why are you worried about TB?
Well, he has a positive quantiferon and he's underweight and he has this huge swelling. I think you're going to need to get tissue and try to get some cultures from that.
Right.
Maybe some more imaging. I didn't notice on the PA view, does he have any spinal, does his spine look okay on the?
Yeah, they did feel like the spine looked okay on the radiograph.
Okay.
Yeah, it was actually seen, we did end up getting a chest CT so that they could look at the spine in more detail. Good question. Yeah. Good. So he did have a CT chest, as you can see here, had actually communication between that soft tissue mass and the pleural space, and that they described it as 11.4 centimeters, enhancing right side pleural effusion that extended through the right posterior chest wall, involved the 7th through 11th rib, and that they described it as something called empyema necessitans. Very interesting. Also had associated right axillary adenopathy, which was not palpated on exam that I remember. Had hilar and mediastinal adenopathy and a multifocal tree and bud opacities and nodules throughout the right lung. So Dr. Smith already mentioned how he should be evaluated. So increased imaging in addition to trying to get tissue. So he was actually taken to IR and that 80 mLs of pink tinged purulent fluid was drained and that 4 pleural biopsies were obtained. His diagnostics, he actually had a repeat quantiferon. I don't know if any of the panelists have a comment on this. The previous quantiferon was 0.7 and 0.85 and repeat was 1.9 and 1.76. And the time between those two was 6 weeks. And he still remained, of low weight when we saw him. I didn't have a prior weight to compare to whether or not his nutritional status had improved that much, but do you guys have any comments on the differences between the quantitative value of the quantiferon?
It's possible it's related to technique, because we certainly know we see false negative quantiferons, in particular when the tubes aren't shaking, when the antigen inside the tubes isn't properly activated. I was going to say at the beginning, and Lindsay, you and I both know that I saw this patient, was, it's interesting how non-robust the initial quantiferon was. I mean, it was weakly positive.
Right.
But he also looked pretty malnourished. And so you have to be really careful about that. So, but why it would change so much, other than technique, or it was on the way up because he was recently infected, but his disease doesn't look like he was recently infected.
Right.
So I don't know if there is a really good answer to your question.
Good. Okay. So the pleural fluid was tested. It was smear negative. That on pathology, they saw degenerated necrotic debris, and it was PCR positive, and cultures were pending. And that the dad actually had a chest radiograph, and this is standard protocol for any child that's admitted to the hospital. Dr. Stark, I don't know if you want to mention the study that was done at TCH on the infection control study that was done.
Yeah, so we've published our data twice from TCH. We've known the original studies were done back in orphanages in Europe at the turn of the 20th century, and they found that if there was an adult in the orphanage with TB, lots of the kids would get TB. But if there was a child in the orphanage with TB, none of the other kids got TB. And that was the beginning of sort of the thought process borne out that children are rarely contagious, but you have to worry about the adult that they got it from. So our thought was, well, maybe the adult that they got it from hasn't been identified, and maybe it's somebody who's actually bringing the kid to the hospital. So we started telling, when we had a kid that we suspected had TB, we did it at our expense, chest x-rays on the parents or guardians, not the whole family, just whoever was going to be with the child in the hospital. And the first time we did this, we actually found a positive rate of 15,000 per 100,000. That is 15% of the chest x-rays we did were abnormal. That is by far the highest positive rate in any screening method for tuberculosis that's ever been described anywhere. That number has subsequently gone down, but is still substantially high. So it's really an infection control procedure to make sure that the adult who the child got TB from isn't roaming around the hospital and infecting other folks. But of course, it also allows us to identify the person and get them into care so that they can have their tuberculosis treated as well. But again, if you have a kid with TB and you don't know who they got it from, it may be from the very adult who brought the kid to come see you.
Yeah, good. Thank you for that. So he was started on right therapy. He also got prednisone for 4 weeks due to concern for a robust inflammatory response within this, the pleural space, in addition to just the inflammatory response due to high burden of TB. And he tolerated it really, really well. He was found to have.
Do you mind if can I make a
Oh, yeah.
comment about that?
Yeah, sure.
So empyema necessitans is not something we see very often in pediatrics. And this is when we actually consulted some of our adult TB colleagues about this, about the corticosteroids, and they felt very strongly that he could potentially benefit. There was, we had tremendous concern about him developing a bronchopleural fistula. And so, anything we could do to cut down the inflammation and promote healing, we thought would be a good idea. And we already knew that he certainly did not have MDR TB and likely didn't have drug-resistant TB. So we felt pretty comfortable also putting him on corticosteroids. It's certainly not a standard indication that you sort of read about someplace, but it made sense to us, and that's why we went ahead and did it.
Yeah, great. There was a comment in the chat that the burden of tuberculosis in Guatemala is quite high. So it's not listed in the WHO as a high burden country, but that 20 per 100,000 is high. In the United States, the incidence is around 3, just 3 per 100,000. So dramatically higher than the United States. But that they think in rural settings in Guatemala that the incidence is much, much higher. And this kiddo came from a rural area. And we couldn't even, unfortunately, find an interpreter who spoke his dialect. So thank you for making that comment in the chat. This was his follow-up in 1 month. So we saw him 4 weeks after discharge from the hospital. And he had a dramatic improvement in the back swelling. So as you can see, all we see is the scar from the drainage. And he had no palpable mass or soft tissue swelling anymore. And his repeat chest x-ray was much better too. Dr. Stark, this is one of the reasons you love tuberculosis, right?
Yeah.
So I'm so grateful that he did so well. His father was actually so scared to have him admitted to the hospital that we had to escort him down to the emergency room. And by the time we saw him in follow-up at 4 weeks, that he was so grateful that the little boy had done so well and that he had responded so well to treatment, and that he came with a smile, and they continued to come with a smile, which was it's really awesome to see them in follow-up.
It's like he already has some calcifications there.
Yeah, I'm not sure. You mean here?
Yeah.
I'm not sure if they didn't actually, I don't know that they mentioned that those may have been vessels. I'm not sure. Yeah.
I'll see.
But it's possible. You're right. He had hilar adenopathy, mediastinal as well. So, okay. Any final thoughts on his case? I have one more case to review, and then we'll open it up to questions.
Yeah, I have one final thought I want to mention. So some years ago, I was privileged to be part of a Centers for Disease Control group that went and reviewed the immigration program for TB at a certain country. I'm not going to mention the country, I guess. And when I went there, I was told by the people running it that they'd never diagnosed a single child who came through for immigration as having pulmonary TB. And I thought that was pretty strange, because this was a country that had an official rate of TB of something like 200 per 100,000. And so I looked at a bunch of chest x-rays, and oh my God, there were a bunch of terribly abnormal chest x-rays. But they had done what they said were sputum exams on these kids, and none of them were positive. So they didn't call any of them TB disease. And I just want to reemphasize the point about the diagnosis of TB in kids. Radiography is really central to that diagnosis. And if we're lucky, with doing everything we can do, we only microbiologically confirm the diagnosis maybe a third of the time. So when we're screening these kids, particularly if they have a positive test of infection, it's really crucial to be critical in looking at the chest x-ray and making sure that it truly is normal, because if it's abnormal, then the positive predictive value for this being TB, if the child has a test of infection, is pretty darn high, and it should be evaluated accordingly. So it's not a microbiologically driven diagnosis, it's a clinical and radiographically driven diagnosis. That's really important.
Right,
You know-
and that I hope that was highlighted in my presentation, that we just have to take the epidemiologic statistics that we have, that are provided, but knowing that a lot of children are not detected because they don't have microbiologically confirmed TB, and that they're not identified because of possibly or mild symptoms. too.
Yeah, I want to emphasize that for our panel physicians, because from a
Yeah.
logistical point of view, if they're, called like a B1 immigrant, they can get lost after coming to the United States, or there can be a pretty significant delay before they can be seen and evaluated. And if a kid, particularly a young kid, really does have early pulmonary tuberculosis, that delay can lead to tragic outcomes, unfortunately. So just really important to be critical in looking at that chest X-ray and getting a really high quality and good technique chest X-ray as well.
Yeah, great. Okay, this is a final case. This was a case that we recently saw. It's a 2-month-old US-born full-term male who was asymptomatic, and that he was exposed to his father, who had been symptomatic for his entire life, the baby's entire life, and was diagnosed with smear positive, expert positive tuberculosis, and that he had moved to the US from Cameroon in early 2021. Eek. So based on this, what is the infant's risk? So the dad is living at home. He's been sick for at least as long as the child's been alive. And how high risk is this baby?
Very,
Very high risk. Yeah, very high risk.
and very quickly too.
Yeah. And as I mentioned in that study, like up to 80% of those who are exposed to a household contact who was smear positive were at risk of getting infected, and then a quick progression from infection to disease given his age, right? Yeah.
Mhm.
And the fact that the man is expert positive was very, very scary. So on evaluation, he was well appearing, had a normal exam, was actually a breastfeeding, very well appearing baby. And his quantiferin was super positive. Dr. Stark likes to say wicked positive. So Dr. Stark or Dr. Smith or Dr. Seaworth, do you guys think that a wicked QFT or quantiferin suggests disease over infection? I don't want to put you on the spot. We don't really have that research done, but would you be concerned about disease more than infection in this situation?
Yeah, so I answered it.
Worried about wicked. Sorry.
Go ahead, Dr. Seaworth. Yeah.
I just said I'm always worried about wicked, but it really does. We see a lot of quantiferin results, and this result like this is pretty unusual. It would get my attention at least.
Yeah.
Lindsay, remind me the kid's age?
2 months.
Yeah, so any test of infection in a 2-month-old that's positive is tantamount to disease. Because these kids have at least a 50% risk of having disease. So usually we start with the child's fine and we try to figure out if there's something wrong with them. In this situation, I would start out that the child has disease and I have to try to figure out if I'm wrong.
Yeah, great. So I had a normal exam and then had an x-ray that actually showed hyperaeration, but otherwise the parenchyma was clear. And then on lateral radiograph as well, there was no concern for adenopathy. So what do you think about hyperaeration? Is that concerning?
Yes. I would be doing exactly what Dr. Stark says, make sure I'm not missing something. This would be a kid, especially, you could see the thymus is a little big. There could be some adenopathy you just can't see. I would get a chest CT or MRI on this kid.
Right.
And Lindsay, based on the chest X-ray, I'm having a very hard time seeing the left mainstem bronchus.
Yeah.
And it looks like what I can see looks narrow. And that makes me concerned that there's something pressing on it, which usually is enlarged lymph nodes, exactly as Kim said.
Yeah, good.
And if that's abnormal, the kid needs an LP.
Yeah, good. So he was admitted to TCH based on his chest radiograph. He started getting first morning gastric aspirates that were all smear negative and TB PCR. We did actually get a TB PCR and then sent experts, even though they're not validated, to ARUP, and cultures were pending. And he did have a CT chest, as you guys mentioned, and he had was found to have a 9 millimeter solid pulmonary nodule in the left upper lobe, in addition to another nodule in the left lower lobe, but then also adenopathy, as mentioned here. And that they thought that the adenopathy was obstructive and that was causing the hyperaeration as well. So right paratracheal nodes and then left hilar adenopathy as well. So Dr. Smith mentioned he should have a lumbar puncture, so to evaluate for TB meningitis, and that he had an LP and CSF evaluation. His white count was a little elevated at 16, but mostly lymphocytes, had a lot of reds, so not a ton, but 2,000 reds. And his protein was also slightly elevated, so we went on and got an MRI of the brain, and that was completely negative. And then we got a TB PCR and culture that ended up being negative as well. So why we're going to treat for TB disease, right? Intrathoracic tuberculosis. Why is this treatment complicated? How do you treat a 2-month-old who has a source case, household contact, who has an expert that's positive?
Well, one reason it's complicated is in the United States, we have virtually no pediatric dosage forms for any medication. So we have to chop up things and crush things. We do have the potential of using isoniazid commercial suspension, and you can make rifampin up into a suspension. But getting the medications into a kid this young who's not taking solid food yet can be extraordinarily challenging.
Yeah. And then also our access in the United States to what they're using internationally, which includes delamanid and bedaquiline, is also super limited, and that they have child-friendly formulations of bedaquiline, delamanid, and even clofazimine, which we don't have access to here in the United States very easily either. So we didn't have the agents that potentially ideally would have used. And so his empiric regimen was actually levofloxacin, INH, linazolid, augmentin prior to the infusion of imipenem, which was a lot for this little child to actually handle. So he had a NG placed for his gastric aspirates, and that we kept it in place to try to get him over the hump of trying to take these medications. But it wasn't easy. It wasn't easy because of the volume, and we had to split these into multiple doses during the day. Thankfully, we got information about the source case within about 2 weeks of it being sent, and that they thought he had something called a silent rifampin mutation, so a molecular mutation, but they didn't think that it was phenotypically relevant. And so that he was thought to be pan susceptible, and then the drug susceptibility testing actually confirmed that he had a pan susceptible isolate. So thankfully, this little boy got to be treated with RIPE therapy, which took him off the IV and then introduced him to the levo and the linazolid.
So Lindsay, I suspect that Dr. Seaworth could probably give us an entire lecture about mutations in the rifampin locus and expert results, if she's willing.
Well, anytime you have an expert that shows rifampin resistance, it needs to be referred to another lab for more definitive testing to determine, is it real? Because it may be a silent mutation like this young child had, which is not clinically significant. It doesn't result in a protein change in the mycobacterium that makes it drug resistant. But there are a wide variety of mutations, and when you get that result from a molecular lab, it can help you determine, is this high-level rifampin resistance or is this low-level rifampin resistance? And what's really important to note is that in individuals who may not have a mutation consistent with high-level rifampin resistance, it is still clinically significant. There have been a number of articles, series, papers, observational data that shows treatment outcomes are much worse in individuals with low-level rifampin resistance treated with the standard RIPE regimen. The other thing that's important to know is your lab may even report, if they're only doing liquid cultures, that the isolate is susceptible to rifampin. But often, if you can get that specimen to a lab that does solid media cultures, they may be able to pick up the rifampin resistance most of the time. There are a couple mutations where it's really hard to even pick up on solid media. But for rifampin, the molecular test is the gold standard, and it trumps the drug susceptibility result. Is that good enough, Jeff?
Yeah. To me, the bottom line is the following. If the expert says it's rifampin susceptible, it very likely is, with some very rare exceptions. But if it says that it's resistant, it isn't necessarily functionally resistant, and further testing really needs to be done to either refute or agree with the expert result.
Agree.
Yeah, and his isolate was sent to the state lab, but also to the CDC. And one of
Lindsay,
the comments- yeah, okay, go ahead.
I have a question. This is Kim Smith again. Did you guys consider this child TB meningitis based on his spinal fluid findings?
We didn't based on, so his MRI didn't show any evidence of TB. And then his culture never grew. So no, we didn't.
So Kim, let me ask you a question. I don't think it would change our initial therapy. How much, I guess the one thing it might change would be the length of the continuation therapy, which traditionally we've done for 9 to 12 months total therapy.
For me, it would change adding steroids to the therapy.
And potentially doing levo and ethionamide instead of the ethambutol, right?
Mhm.
We thought with only 16 white cells and with no evidence by MRI that the inflammation was not contributing to pathophysiology. And to be perfectly honest, I don't start steroids lightly in kids with TB because it's sometimes very difficult to wean kids off, particularly if there are language and cultural issue differences between physicians and patients. So we talked about it a long time, and we thought that we probably didn't need to, but you're bringing up a really good point about making darn sure you're comfortable with not doing that.
The part that worries me on this would be I know granted it is a low white count, but it's still abnormal. And also the protein being 99, I would have been concerned about meningitis in this patient, even with the normal MRI.
Yeah, I mean, I think by definition, this child has meningitis. And so I agree with you. The issue for us was whether we still needed to do the corticosteroids for the management. We elected not to. But it was a clinical decision.
And with a normal MRI, you could say, well, probably less severe or just early meningitis.
With this child, my guess would be, had he not been treated and you repeated the LP and the MRI in 2 or 3 weeks, it would have been easy to diagnose meningitis.
Oh yeah. No,
Yeah.
I think he would have been in trouble if this had gone on much longer. I totally agree.
Yeah.
So I think it was that just, I mean, it was just very early. You caught it really early. You diagnosed it really early.
Right.
And
Yeah,
Lindsay,
his gastric aspirates didn't grow. We did an abdominal ultrasound to see if there was any evidence of hepatosplenic lesions, and that was negative too. So we didn't do a mycobacterial blood culture just to see if, but that was negative too. But you're totally right. I mean, we talked about the CSF findings, and he did have a completely normal neurologic exam. Was thriving. And really had no pulmonary symptoms at all either. I mean, including no significant tachypnea and definitely no wheeze on auscultation. So.
And Lindsay, we have some follow-up now, right?
We do. Well, he was seen in clinic a month afterwards and doing great. We didn't do any neural imaging afterwards, but we did a repeat chest X-ray, and the hyperaeration had improved.
Yeah, and he's growing and developing
And
and
he's
gaining
growing
weight
and developing
and
totally
neurologically
normal.
developing normally.
Yep. One thing that was unique in his aspect was that we do use high dose rifampin in young infants. And so he got 35 milligrams per kilo. And this will be discussed at a future webinar about the use of high dose rifampin in young babies. So. I think that was all that I had for the cases. And at this point, Delphina, unless there are any final comments about the case, that we can open it up to question and answer.
Yeah, definitely. So there is a question in the Q&A pod. Why is it a silent, in quotes, RIF mutation?
Well, silent mutation just means it's a change in one of the base pairs from what's normally found, but it doesn't have any functional significance. In other words, that change does not confer rifampin resistance. So it's clinically or functionally silent mutation.
Right, thanks, Dr. Stark. Let's see, and then there's 2 questions in the chat. And please let me know role of steroid in this case.
Yeah, I think we answered that question that we didn't do steroids in this situation. He wasn't treated with steroids.
Okay. And then now would there have been abnormalities in the neuro exam for the child? And I apologize if y'all already addressed that one.
Well,
So
I mean, that's actually a really good question. We have seen other children, we've seen several children now who have pretty extensive pulmonary disease, have stone cold normal CSF findings, but we've done neuroimaging and they have multiple tuberculomas of the brain. We've seen at least 3 or 4 kids like this in recent years. So you certainly can have significant CNS disease even with a normal LP and with no neurological findings at all on the exam. So, you know, it's certainly early on in TB meningitis, the clinical abnormalities are sort of non-specific flu-like, and at that point, their neurological exam might be normal. I mean, I agree exactly with what Kim said and what Lisa Armitage said in the chat. You have to consider that this child had very early TB meningitis. And as I said, the decision to not give steroids was a clinical decision based on the child's overall presentation. You know, usually when you see kids with TB meningitis, you don't ever have the opportunity to diagnose them this early. They come in sick.
Right.
And then it's pretty obvious that we need to give them corticosteroids. But this one, I think it was all, I don't want to say incidental finding, but it was, you know, not what brought the kid to attention. But this is exactly why we recommend for kids less than a year of age with TB disease, we do an LP, because we do pick up cases of early meningitis sometimes. And it does usually affect their treatment.
So this is not unusual in adults either, that you, or not, I shouldn't say unusual, but it's definitely a possibility that you can see multiple nodules on MRI of the head, and the patient has no neurological symptoms or findings and is alert and oriented. And so sometimes in the presence of disseminated disease, whether that's in a child or an adult, it's important to consider, is there silent neurological disease or CNS disease rates in that individual?
Yeah, you know, it's funny. Lindsay's heard me say this a few years ago. I was privileged to be at an NIH symposium on TB meningitis. And it was really the world's experts in TB meningitis. I'm not quite even sure why I was there, but 30% of the meeting was about killing the organisms, and 70% of the meeting was about inflammation and controlling the inflammation. And it's so interesting what affects people's ability to make inflammation, and how I think some of these patients with tuberculomas, they just don't have much inflammation, and that's why they're clinically silent, and that's why they seem to be doing well otherwise. And then other patients have horrible inflammation. And there's no question the worst inflammation to have is with neutrophils. Neutrophils in the CSF are really bad if you have TB, if you have CNS TB. So we're, I think, in our infancy of really learning about the interaction between the organism and the inflammatory response. There are some patients that paradoxically do worse on steroids. And there are some patients that paradoxically do better when you give them medications like infliximab, which actually has a black box warning about TB, but you also, of course, are treating them for TB at the same time. So the inflammatory part of CNS TB is really interesting and really complicated.
All right, so we have about 10 minutes left, which is what we had allotted for Q&A. And that takes care of the questions in the Q&A pod. So I'm going to bring up this Word document. I don't know, I don't think that we'll be able to get through all of them. It looks like there's probably like a good 10, 15 questions. So give me a second to bring this up. And hopefully y'all can see the, let's see, there we go. Can y'all see that?
Yep.
So again, these are questions that came in from our panel physicians during the registration process. We asked them to list 3 questions that they would like answered during this session. So I'm going to go ahead and let our panelists see which ones you can address for the time that we have left. And then we can address the rest of the questions later, and I can post them, save them to the panelist physician page on our website.
Jeff, can you respond to that first one? Is there a plan to update any requirements?
I don't know the answer to that question.
I don't either.
And Lisa knows more about this than I do. Lisa, do you know, is there any plan about that?
Dr. Armitage, let's see, I think she responded in the chat.
I think she might be flying, actually.
Yeah, she was just about to board her plane in a few minutes.
Oh, okay.
So yeah, she was on for the time that she could be.
Yeah, I'm not aware of any changes, but to be honest with you, I wouldn't necessarily be. don't have inroads into that. So sorry, but we can try to find out and answer that question. You know, in the next seminar that we do, try to provide that answer.
So it looks like we've actually answered a number of these. Pregnant women may be screened through an IGRA. Yes, they're valid in pregnant women as they are in pregnancy as they are in other individuals. Sputum culture is mandatory in patients with HIV, likely because it's not uncommon for an individual with HIV disease to have a completely normal chest X-ray and still have a positive sputum culture. If they were clinically well, history was absolutely no indication at all of signs or symptoms, that might be less common, but we definitely can see positive sputum cultures with HIV. Some studies have reported up to 30 to 40% in different populations. So I think that was probably behind that. I think Lindsay did a wonderful job of describing the epidemiology of TB and has answered most of those questions extraordinarily well. Diagnostic approach in low TB incidence countries, being this is in children, I don't know. I do think again that Lindsay, you answered most of these questions that are on here. So
That's good.
I think you did a great job.
Thank you.
How about that? You want to talk about expert TB and feces in children? And is that going to be included in guidance?
Yeah, there was actually a really neat study that evaluated expert both in stool and urine and nasopharyngeal samples, actually, as diagnostic tests to evaluate children who had suspected tuberculosis based on symptoms or radiographic findings or both. And that the studies are ongoing to try to validate each individually. But what the study actually found is that the sensitivity increased the number with the total number of tests that were actually used. So the sensitivity to diagnose tuberculosis was best if you used multiple methods of identification to diagnose pediatric tuberculosis. So,
Jeff, you want to mention the short treatment regimens, or are we getting to that in another presentation? I suspect we are.
I think we are. I think, yeah.
Yeah, I think we'll have that in another presentation, but just, I mean, there's 2 4-month regimens now for young children and for teenagers that have been endorsed by WHO, and we're working through the endorsement process for the United States. So people will be hearing a lot more about that. The other thing about the study that Lindsay was talking about diagnosis is that they found, and other people found this too, that testing for TB in multiple samples from different parts of the body, stool, urine, gastric sputum, et cetera, doing that once actually gets higher results than doing, say, 3 different gastric aspirates. So sort of a one intensive investigation using a variety of potential sources of finding the organism is probably more effective than trying to do repetitive testing from one source over a period of several days. The traditional 3 early morning gastric aspirates, in other words, it was better to look at multiple samples from the same child at the same time.
Which is
Do you
great,
have any-
and you won't need repeat visits to the clinic, right? Which is sometimes the complexity of visiting
Yeah,
the center
exactly right.
multiple
Yeah.
times. Yeah. Yeah, sorry, Kim, for interrupting you.
Yeah, great presentation, Lindsay, and excellent cases. Can you and Jeff comment on the issues around expert not being approved in smear negative samples or in extrapulmonary samples in the United States?
We
I'm gonna
just talked about
say,
this on Tuesday.
yeah, Lindsay will hear me rant again.
Me
Yeah,
too.
like, for instance, we can't get it done on stool, even though it's endorsed by WHO, and there are in fact standardized procedures. Our laboratory has been very, very reticent to do it because of lack of FDA approval. Anybody who does pediatrics know that we don't have FDA approval for probably at least half the things that we do. So, you know, it's funny, Kim, in terms of diagnostics and now in terms of therapeutics with the dispersible medications, the United States is actually far behind many other parts of the world in terms of the ability to diagnose and manage TB in kids. It's really a shame.
Yes, it is. I find it really frustrating because the literature shows how much better expert is.
And I believe we still don't have expert ultra in the United States either.
And probably aren't going to get it.
Right,
Oh.
because again, because of regulatory problems, even though the literature shows clearly that it's better.
And would be even better yet for children, probably than for adults.
Correct, because it's more sensitive.
Yeah.
The last thing I read is it can detect down to 16 organisms per cc as opposed to 131 organisms per cc with the traditional expert. That's a big difference.
Great cases, great presentation.
Thank you so much. Thanks for attending, Dr. Smith, Dr. Stark, and Dr. Seaworth.
Thank you.
Dr. Armitage was here too. It sounds like on a plane. Amazing.
Yeah,
So
so
if those who are still in the audience, if you guys could take 5 minutes to evaluate this experience, the webinar, the lecture, in addition to the cases, we would appreciate your feedback. And I hope that we provided a nice primer for the lectures to come, so that this was an overview on the epidemiology and the complexities on evaluating the epidemiology of pediatric tuberculosis in those in pregnant patients, but also a lot of complexity in diagnosing TB and evaluating those who are at risk of tuberculosis. So we appreciate your attention, your questions, and we look forward to seeing you all in future lectures and presentations. Hopefully it was useful for you all as well.
thank you so much to all of our TB experts and to our participants. We'll see you all next time.
Thank you, Delphina, for your support. You've been amazing.
Thank
you.
you. Bye, everybody.
Bye.
Bye-bye.